Welcome to this special clinical series, From Vascular Curiosity to Neurodegenerative Disease, a consensus statement for the diagnosis and management of MACTEL Type 2. For decades, macular telangiectasia type 2 was viewed as a vascular curiosity characterized by its subtle vascular abnormalities, including telangiectasia vessels and late-stage leakage. Emerging research and clinical consensus, however, have shifted the paradigm of MACTEL type 2 from a primary vasculopathy to a complex neurodegenerative disease centered on the dysfunction of Müller glial cells, which support both the functional and structural integrity of the retina and the subsequent loss of photoreceptors. As the understanding of the metabolic and genetic components of MACTEL type 2 evolves, clinicians are recognizing that standard metrics of visual function, specifically Snellen visual acuity, are insufficient for capturing the true burden of the disease. More appropriate measures include difficulty reading, metamorphopsia, and paracentral scotomas. In this 4-part video compendium, an expert consensus group of renowned retina specialists help us move beyond the traditional eye chart to explore the metabolic underpinnings, multimodal diagnostic protocols, and emerging neuroprotective therapies that are transforming the standard of care. Join us as we explore these perspectives to ensure that no patient is left behind in the Snellen trap. And for more details, we encourage you to use the QR code on this screen to read the full written consensus statement. Müller glial cells provide structural and neurotrophic support. In MACTEL, Müller glial cells experience apoptosis and resultant retinal neurodegenerative effects, macular photoreceptor loss, and ganglion cell loss. This causes impaired central and sharp vision. Ciliary neurotrophic factor, or CNTF, is key to protecting retinal neurons. When CNTF binds to receptors on Müller glial cells, it produces both growth and neuroprotective factors to provide structural support and activate cell survival pathways. This enables macular photoreceptor protection. In clinical trials, ocular delivery of CNTF has been shown to significantly slow progression of MACTEL.
So there's been a lot of preclinical data showing, first of all, that the CNTF protein stimulates the Müller cells to produce neuroprotective factors. So I think, first of all, that's important. The second thing is the encapsulated cell technology has also been shown to enable continuous delivery of CNTF to the retina over a long period of time. So I think both those data points combined really give us excellent confidence that the CNTF can not only protect and preserve the photoreceptors, but that we do have a vehicle to deliver this for the long term.
The phase 3 and phase 2 clinical trials, and when you pool all of the data, the phase 2 and the two phase 3 studies, I think it shows very consistent protection against photoreceptor loss. I think that data is pretty clear cut across all three, so that gives me a high degree of confidence. And then when you pool the functional testing in terms of microperimetry and reading speed, we see protection on a functional level, something that we haven't actually seen so clearly with GA, but in MACTEL with this CNTF implant.
In fact, the MACTEL expert consensus group unanimously agree they are either very or moderately confident in the neuroprotective mechanism of CNTF as a therapeutic approach to MACTEL. Encapsulated cell therapy, or ECT, was first demonstrated by Vincenzo Bisceglie in 1933. With ECT, living cells within a semi-permeable polymer immune protective membrane are genetically engineered to treat a disease or condition. ECT is versatile and can be customized to produce a variety of therapeutic proteins, including antibodies, fusion proteins, growth factors, and small peptides. Today, one promising ECT is NT501. This implant, comprised of human retinal pigment epithelial cells that have been genetically modified to release clinically relevant levels of CNTF, has been shown to provide long-term CNTF delivery into the vitreous cavity. NT501 is a semi-permeable hollow fiber membrane that is implanted into the vitreous cavity and secured to the eye wall. Clinical studies have demonstrated the cells inside NT501 remain viable for years, allowing long-term continuous therapeutic protein delivery. It can function under conditions with both low oxygen and nutrients, making it particularly suitable for the intravitreal environment.
Well, the mode of delivery is fascinating, actually. It's like science fiction. Basically, we have retinal pigment epithelial cells that are living in this little capsule, and they maintain their function because they're getting oxygen and nutrients through the vitreous. But these RPE cells were genetically engineered with a plasmid that releases CNTF, ciliary neurotrophic factor. So it's a combined cell therapy and gene therapy approach, and then the CNTF continuously releases from the capsule and diffuses through the vitreous cavity and hits the target tissue, which is the retina. Multiple cell types on the retina could be affected by CNTF, but predominantly Mueller cells, but there's other cells that have receptors for CNTF. So it's pretty ingenious that this little capsule gets placed in the eye. It's sutured to the wall of the eye, stays there.
It is very cool technology that we're implanting live cells inside the eye that are essentially, we're using as the production cells to produce CNTF to help for that protein to really support the light sensitive cells, which are the photoreceptors in the back part of the eye. We know from the clinical trial data that they have to explant those devices or that implant about 5 years into the trial, and they showed that the cells are still living and producing. And if I have my data correctly, the first patient ever receiving this therapy still has the implant and is doing well, and it's a couple of decades into it.
Basically, what you're trying to do is slow the disease down, because remember, these patients are slowly walking towards the edge of a cliff. And what you're trying to do is slow down the rate at which they walk towards the edge of the cliff to give them more time before they fall off, and maybe even all the time they need, such that they're seeing well until, the day after they die. So to me, that's kind of the goal here, is how do we put this thing, if not in full hibernation, like totally stopping it, at least slowing it down to give patients a longer amount of time with, as much functional vision as possible.
"100% of the MACTEL expert consensus group said the primary therapeutic goal of ECT delivering CNTF is to stabilize or preserve photoreceptor function."
It's a therapy that shows it can reduce the rate of progression of ellipsoid zone loss over time. It can also reduce the loss of reading speed and retinal sensitivity as measured by microperimetry. So we do have, in addition to the anatomical endpoint, we do have some secondary endpoints that suggest it can slow down loss of visual function. And in some of the data, even the combined data, there's trending towards reduction in visual acuity, and that'll probably pan out over time. So it's a therapy that's going to reduce the loss over time. So we expect that patients are still going to lose some vision, but at a slower rate. So it's a very different conversation. Most of the time when patients come in to see a physician, they want to be cured, right? So they want their vision back to where it was before they started to have visual problems. This therapy is not going to do that. The therapy is also not going to stop it from progressing 100% either. So it's not even that we can say it's stopping the disease. We're saying it's going to slow down the disease.
And so the key here is to decrease the damage to photoreceptors so that we can retain retinal function for these patients that have an otherwise untreatable disease.
Thank you for joining us for this video compendium on MACTEL Type 2. As we journey from the microscopic failure of serene metabolism to the macroscopic challenges of differential diagnosis and the surgical frontiers of neuroprotection, the goal is clear. Increase awareness, utilize multimodal imaging, and intervene within the therapeutic window to preserve visual function. This shift from observation to intervention marks the beginning of a new chapter for patients with MACTEL Type 2. While the surgical and pharmacological frontiers are still expanding, the foundational goal is vision preservation. By identifying patients early and utilizing these emerging tools, clinicians can finally offer our patients hope for a stable visual future. In the next video, the MACTEL Type 2 Expert Consensus Group discussed patient education and counseling. For more details, we encourage you to use the QR code on this screen to read the full written consensus statement. Together, we can move from passive observation to active preservation.